everyone. In this episode, I interview Professor Sudha Sundar about ovarian cancer. If you enjoy these podcasts, please subscribe. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor Sudha Sundar about ovarian cancer. Sudha is a consultant gynecological cancer surgeon and clinical academic. Her research interests include cancer diagnostics, cancer surgery, and inequalities in cancer outcomes. She's also the immediate past president of the British Gynecological Cancer Society and therefore superbly placed to educate us about ovarian cancer today. Sudha, welcome. Thank you so much for joining me today on the show.
Thank you for inviting me. I look forward to having a conversation with you.
So, Sudha, I'm always really interested to find out why distinguished colleagues like yourself chose their particular field of medicine in which to work. So, can you tell us, why did you choose to work in the field of ovarian cancer?
So I think I've had a few blessings in my life, and medicine is one of them. Because I consider myself enormously fortunate to have walked into what I was going to do purely by accident. I didn't have any, every Asian child aspires because of parental pressure to be a doctor. So I don't know that a lot of thought went into becoming or as applying to do medicine. But when I got into medicine, in a medical school in India, I realized I had found it. And I think we're very lucky as doctors, actually, to find it so early. Lots of people don't find it. And then it was quite clear to me by my final year in my house officership that I wanted to operate. So I really, because I loved operating, I loved being in operating theatre, I didn't feel tired. So I knew I wanted to operate and to become a surgeon. At the time, there was more family support to do obs and gynae, and general surgery wasn't considered a suitable career choice. So I went with the one that had the most family support, and that's how I ended up in gynecology. But in actual fact, I've veered from obstetrics and gynecology to effectively doing more and more and more surgical work, to the extent that now I only do gynec cancer surgery. So in the end, I've ended up where I started, but it was essentially to operate. I was phenomenally fortunate at the age of 30, for various reasons, for getting an opportunity to work at the Weatherall Institute of Molecular Medicine as a CIUK research fellow. Again, purely stumbled into it by accident. And then my mind was opened to the possibility of research and what was possible to achieve by an inquiring mind. And that bug to combine asking questions and operating has never left me, and is the reason why I do the job I do.
Wow, that's really, really interesting. Thank you. No, it's a great answer, though. It's a great answer. And it's interesting in doing these interviews, it's interesting how early everybody says they either decided I wanted to operate or I knew theatre wasn't for me. So that's really, really interesting. I think that's the first decision, apparently. Yeah.
So go ahead. So one of the things that I remember also, as soon as I finished my house jobs, I got posted into the women's obs and gynae department. And in those years in India, the junior most person got posted to the cancer wards. And because it was perceived that you could do no harm. So it was okay to let you be on the cancer ward. I, on the other hand, loved it because you could make a difference very easily just by turning up, making sure people were controlled with symptoms, given some blood, the expedited referrals. So, I wanted to do cancer from very early on in medicine.
Okay. So, Sudha, as you know, this podcast aims at educating patients. And as a result, we try to avoid medical terminology as far as possible in order that it remains as accessible as possible to everyone. So let's start with the basics. Where are the ovaries and what do they do?
So the ovaries look like almonds, tiny little structures. They're about that big in normalcy, and they're tucked in the pelvis, which is the bony bucket on which we stand, basically. So if you feel the top of your hips, that's the top of your pelvis. The pelvis is like a bucket, so it's like that, and the ovaries are tucked in the sides of the bucket. And the ovaries are attached to the womb. So I like to describe the female organs as a pear. The womb is like a pear, and the ovaries basically are like little almonds that come off the top of the pear. And that's how I describe it.
Okay. And in terms of ovarian cancer, are there different types of ovarian cancer, or is it just one single diagnosis? Everyone is the same?
Thank you. I think that's an incredibly important question. I think we're learning more and more that ovarian cancer is an extremely it's a basket of cancers put into one term called ovarian cancer, and how an individual woman will respond to treatment, respond to surgery, respond to chemotherapy, and the drugs that are appropriate for that person really depends upon the particular type of ovarian cancer that she has been diagnosed with. So ovarian cancer is a number of different cancers, and it's really important for women and their families to really engage with, apart from the stage that I think most people are fully aware of. They also need to understand their particular type of ovarian cancer and what the implications of that are.
Okay. And what is it that the ovaries do? What are I mean, it seems a bit funny asking this because I'm a gynecologist too, but can you explain for the benefit of our patients what ovaries do and why they're important?
Thank you. So the ovaries are the equivalent of the testis in the man. Um, so they are incredibly important because, in a sense, they regulate everything about us in terms of when we get our periods, how our periods function, the production of hormones that make the breasts grow in young girls, pubic hair grows. So all of these are hormonal effects because of the hormones that the ovary, amongst other organs, produces. So they're responsible for the development of our features. They're responsible for our periods. They're responsible for the regular sort of shedding of the period blood or the cycle. They regulate that. When the ovaries are also incredibly important because they produce the eggs that then travel through the fallopian tubes, or the little sea anemone type structures that are attached to the ovary, and then transport the eggs in through the tube into the womb, which is the pear. And obviously, when a sperm meets the ovary at the right time, then that forms a baby that grows in the pear, i.e., the uterus or the womb, to form the baby in the future. So they're incredibly important, and the ovaries so more or less come to the end of their function around about the time of the menopause. Um, and it's an incredibly important, crucial part of who we are as women.
Yeah. So just to summarize, they produce hormones and they produce eggs that are important for fertility and pregnancy. Yeah. Okay. So I always ask about risk factors for conditions because there are some risk factors that you cannot change, for example, your genetic makeup, but there are others that perhaps modification in lifestyle can decrease the risk of someone getting any particular condition or maybe decrease the severity. Are there any risk factors that you can tell us about for ovarian cancer? Is there anything that women can do to reduce their risk of getting ovarian cancer?
Thank you for asking me this important question. We know some things are quite important, which is that amongst other cancers, being slightly overweight increases the risk of ovarian cancer. The things that are protective are the oral contraceptive pill actually protects women from developing ovarian cancer. However, I think that people should make a decision on their contraception based on what is appropriate for them at the time rather than a risk of ovarian cancer, which is a relatively rare cancer. I think one of the other things that really does help people in being vigilant is a family history of ovarian cancer, which is or breast cancer. I think is quite important because we do know that there are genes that are, if inherited, if inherited, so they call them mutations, but actually the better word for them is inherited misreadings of the gene. If that runs in people's families, then it would be really good for people to be vigilant about it, because it would be then possible for women with a higher risk of ovarian cancer to be monitored, to have earlier removal of the tubes and ovaries if necessary. Having a family history of ovarian cancer and breast cancer is something that people need to be really quite vigilant about.
Okay. And in terms of screening, so you mentioned about being vigilant. So most women will be aware, for example, and you will be very aware of the cervical screening program, where women are invited for smear tests every 3 years, etc., and then every 5 years after 50. And that's a screening test for cervical cancer. Is there a similar screening test for ovarian cancer?
Unfortunately, we don't have a similar screening program for ovarian cancer. And large trials have been run and have not shown, unfortunately, a benefit to women from being screened regularly for ovarian cancer. Now, that may change in the future because there's lots of research going on to try and understand where ovarian cancer comes from. But at the moment, we don't have a screening program or an effective screening test that can pick up ovarian cancer before it occurs.
Okay, so I guess then the most we can hope for then, I guess, is early diagnosis rather than screening before it becomes cancer. And what are the symptoms that you would advise that women look out for? So women perhaps with a family history, or just any woman, what are the signs, what are the symptoms of ovarian cancer that you think, ooh, maybe I should go along and be investigated for those symptoms?
So it's really important for me to say here that the vast majority of women with ovarian cancer actually won't have a family history with ovarian cancer. We know that some women will, and in a sense, it's for those women that I say it's important to be vigilant. But the majority of women actually will not have a strong family history of ovarian cancer or breast cancer or colon cancer. One of the challenges with ovarian cancer is that the symptoms are so vague. And often women will come to my clinic saying, well, I just thought I'd put on a bit of weight and my trousers had gotten a bit tight. I thought that that was what it was about. It's partly because the risk of ovarian cancer kind of goes up once you're past mid 40s, and the peak actually is in the 60 to 70 age group, and the 70 to 80 age group. So it's slightly older women who may be feeling some. So they've noticed maybe over the last couple of months that they're feeling a bit nauseous, that they get feeling full quicker, that they have discomfort. And I use the word discomfort very deliberately because, again, often people don't have the sort of sharp pains that they think they should be having to warn them. This is much more in the form of grumbling discomfort that they have in their tummy. And they have this quite frequently. So perhaps they have it, say, 10 to 12 times in the month. So quite frequently, so a couple of times a week, they have this discomfort, this pain. Maybe they feel a pressure sensation, so they feel like they have to wee more often. Maybe they feel like they want to open their bowels, so poo more often. Maybe they have noticed something change in their tummies, and that their trousers or skirts are getting tighter. Occasionally, some women will say, I felt tired, I felt I had to sit down a little bit more. But because things happen quite slowly and over time, people, when I say slowly and over time, I mean in the form of months rather than days, then people don't maybe flag that up to themselves as there is an issue. What we
Yeah.
do know is that, so the most important thing is that often women with ovarian cancer will go 3 times to see their GP. And this is, I'm quoting research here. They often will go 3 times to their GP before they get flagged up or tested for suspicion of ovarian cancer. And that's entirely understandable in a way, because ovarian cancer is a very rare cancer. And only a GP will see this maybe one in of 400 women. The GP that the GP sees, one of them will turn out to have ovarian cancer. So if you can see a cinema full of women,
Yeah.
one of them will have ovarian cancer, but 1 in 2 of them will have some of these symptoms in their lifetime. So really, it's for individual women to say, well, actually, this is different for me, and flag that up that this is different. The other thing that I will say is often we attribute these things. It's really important to know your own body, and when it's different from the previous 6 months, then actually keep a symptom diary. It's not, it's, I find it incredibly difficult, even for myself, actually working out whether I've had a symptom or haven't had a symptom. So my suggestion to your viewers, if you feel something's changing, just take a blank piece of paper and just write down how frequently you're experiencing it. And then then it's obvious that there's something that's happening. Otherwise, we tend not to. I mean, even heavy periods, people will put up with dreadful periods because once it's gone, and you don't remember it until the next time around. So it's that sort of thing. It's if we're able to write down what we have, then people can remember what symptoms they've had. And it's very important not to hang these symptoms on, oh, I've got irritable bowel syndrome, because that's the most frequent thing that people think they have. But irritable bowel syndrome tends to be there for years, decades. So if there's something new that's happening in the last month, 6 months, 3 months, then flag that up, go and speak to your GP, get tested. So I've described so far the symptoms for ovarian cancer in the majority of women who tend to be older. We do know that sometimes we have a particular kind of ovarian cancer. They're called germ cell tumors. They respond extremely well to treatment, extremely, exceptionally well to treatment, but they tend to occur in the younger women. So women in their sort of any time from their 20s to their early 30s, and the teenagers. Again, exceptionally rare cancers, but often then they notice a swelling in their tummy, and that's how they get flagged up. But certainly, if women feel that they can feel a swelling in their tummy, then please to take it seriously. Please to go and see their GPs, and because women know their bodies, and if you feel that you've got a lump in your tummy and you can feel that lump, then that's a lump that exists unless proven otherwise. So we need to learn, I think, to listen to our own bodies and take ourselves seriously. But I would seriously recommend, if people have any concerns that things are changing for them, to just write that down and put it up in a calendar, and then you can see for yourself that things are changing. Because otherwise, in the sort of lives that we live, you forget about these things.
Yeah, and I think that's really, really important. What you've just said, that's an important take-home message, particularly for teenage girls who quite often will minimize things, or they'll Google things on their own and they won't tell anyone. And I've had, you may or may not know, an adolescent gynecologist as well, had girls who come with really big ovarian cysts, and when you talk to them, they've had it for a long time, they've been aware of it, but they've not mentioned it. So yeah, that's why I do this podcast, so that we can get
Mhm.
reliable information and education out there to the women, the girls who need it. So the take-home message is, if anything is unusual for yourself and reasonably persistent, please go to your GP. It can never hurt to go to your GP. Even if it's nothing, then at least you've got that reassurance. Do you agree?
Absolutely, absolutely. And the initial tests are quite easy tests. They're not complicated. We can always help. So eh, don't be put off by, I don't want to bother the GP, or I don't want to, or any fear or nervousness, because we can help.
And I guess it goes without saying that with every single cancer, the sooner you do seek treatment, the sooner it's diagnosed, then the better the outcomes. Is that so for ovarian cancer as well?
100%. I couldn't agree with you more. Because we know that we can treat women, and we know that we can treat women effectively, but women's health and their own the body's ability to withstand treatment is a very big factor for that. So yes, I think that's incredibly important.
Okay. So supposing I'm a woman and I've got these symptoms that you've mentioned, so a bit of bloating, maybe some indigestion, my trousers are a bit tight, some pressure, that feeling of pelvic pressure, and I think, okay, I will go along to my GP. What investigations, what should patients expect when they do go along? How is this diagnosed?
So I think it's really helpful when you go to speak to your GP to describe these symptoms, to say they're persistent, to say that they are happening quite frequently. You can take your symptom diary with you if you would prefer,
Yeah.
because I think people forget when they go along as well. It's perfectly normal. I do it all the time. So I think having this list, thinking about what it's stopping you from doing is quite important. I used to be able to do shopping and heavy lifting. I'm not able to do that now. So I think it's quite important to know that for yourself, but also be able to say it, I think. So if you see your GP face to face, then they may want to have a feel of your tummy, to have a feel to see whether they can feel any lumps or bumps. They may send, so if you're speaking to them virtually via a telephone conversation, they may ask you, or they will ask you, to have a blood test. And that blood test is for a test called CA125, and that's a substance that cancer cells produce. It's also a substance that lots of other things produce. So just because you have higher levels of CA125 in your blood, it does not mean that you definitely have cancer or definitely have ovarian cancer, but it's helpful as a warning sign to suggest that we need to find out a little bit more about what's going on for you. So we know, especially for younger women, CA125 can go up with periods, can go up with tummy discomfort. So it's really just a stepping stone, and then we need to get it done. But it's really important to recognize that it's not. It doesn't mean it's not a sort of. It does mean if you've got it and it's higher that you definitely have cancer. The next step that the GP will want to do is that they will then, if you say 125 is higher, they will request an ultrasound scan of your tummy. Ideally, it would be lovely if women could have both a tummy scan and an internal scan, because it's possible to see your ovaries much better with an internal scan. That's a little bit uncomfortable, but it's well worth, if you can, having that done, because then the information that we get is better than just having a tummy scan alone. For the internal scan, you don't need to have a full bladder. So although they'll get you to drink up and it's a little bit uncomfortable, really they can get you to go and have a wee and then come back and have an internal scan. So the internal scan is quite useful. If the internal scan also picks up a few abnormalities, then the GP will send you to the hospital for further testing to see a gynecologist, maybe a repeat scan, and then the gynecologist will make an assessment based on more testing as to whether you need to be whether there's any problems with your ovaries that warrant us to do more tests like a CT scan, keyhole surgery, or open surgery. But the majority of women who are tested for CA125 or for ultrasound or see their gynecologist or end up in hospital will turn up not to have ovarian cancer. So that's really important. So your chances of not having ovarian cancer are well in the 90%.
Okay, thank you. That's really clear. I just want to add a little question to that. So a woman who has these symptoms, and I bring this up because I'm asked so much, and it's really good that women put so much reliance and are so trusting of the smear program and smear tests. But it's also important that they understand that the smear test will only screen for cervical cancer, because I have women who, patients who say, oh, well, I've had these symptoms, but my smear is okay, but so surely I can't have ovarian cancer. So smear tests do not rule out ovarian cancer. Is that correct?
That is absolutely correct. So it's really important for people to recognize that smear tests only pick up abnormalities in the cervix. So when we go back to what I said at the beginning, that the womb is like a pear, the stalk of the pear is the cervix. And all they can see when they're doing this cervical smear is the stalk of the pear. The ovaries are like almonds and they're tucked up by the top of the pear, by this bulgy bit of the pear. So it's impossible. No one can figure out that you've got ovarian cancer from the little stalk of the pear that they can see. And the cells that are picked up are cells from the stalk of the pear, not the top of the pear. So the cervical cancer screening program is just to pick up cervix problems. It's not to pick up womb problems or ovary problems.
Correct. Okay, thank you. So again, going along the patient's journey. So I've had the symptoms. I've gone along. I have had my CA125 blood test and my ultrasound scan. I've been referred to hospital. You've done further imaging, further investigations, and I've been given a diagnosis of ovarian cancer. What happens next? What are the treatment options? What should I expect from the rest of my journey?
Okay, so the first things first is that there's good treatment options available. So I think receiving a diagnosis of cancer, receiving a diagnosis of ovarian cancer is obviously a huge thing for anyone, and it's entirely understandable if people feel a bit like the sky is falling down upon them. But we have good treatment options that are available, and that it's important for people to seek those treatment options. There are several cancer charities that have excellent information available on the internet in terms of preparing for a diagnosis of ovarian cancer. So I would really suggest that your listener basically look at some of those websites, because there's a lot of information out there for women. So that's the first thing I would say. The second thing I would say is that in the UK, every patient with ovarian cancer should have an opportunity to meet or at least talk to a clinical nurse specialist who will be helpful to be able to provide them with information about the treatments that they are having. Of course, they will meet their oncologist, their cancer surgeon, the other members of the cancer team, but sometimes it's helpful to have a point of contact. And in the UK, that this is something that we have been providing. So women should be given written information in terms of what the diagnosis is, what the stage is, and supporting information that they can then take home to digest and sort of have a think about what it is that this means for them. The gold standard of treatment for ovarian cancer, or for the majority of ovarian cancer, will be some form of surgery and chemotherapy. So that is the gold standard, and that is what we aspire to do for women with ovarian cancer. Exactly what surgery it involves, and exactly how much chemotherapy and when the timing of this is, will depend upon that individual person and that individual person's circumstances. But that is certainly what the aspiration will be for each individual person. So, my suggestion to your listeners is to recognize where they are in terms of their fitness, but also then really have a conversation around these two options, surgery and chemotherapy, with their cancer treatment team.
Okay. Okay. And so there are various options, and treatment, what I'm getting from you is treatment is highly individualized depending on the woman, her general condition, what type of tumor, I imagine, and the stage at which it has been diagnosed.
That's correct. But the gold standard for almost all, I mean, the gold standard, as in what we aspire to do, would be a combination of surgery and chemotherapy for
Surgery and
majority of
chemotherapy.
women. But obviously, that's these are huge, big words, surgery, chemotherapy. So the actual nuance of that will depend a lot upon that individual person.
Yeah, okay, great. And can you give us an idea? And I know this is highly variable, again, depending on tumor, depending on stage, etc. But can you give us an idea about how successful treatment is for ovarian cancer these days?
So it depends a lot on the particular type of ovarian cancer. So, for instance, the tumor that I talked about earlier, called germ cell tumors for
Hmm.
younger, that can occur in younger women, have excellent survival rates. Excellent survival rates. So we would really be looking to treat very, very successfully for the majority of younger women who have germ cell tumors. For the more common variety of ovarian cancer, again, the majority of women will respond, and this is a particular type of ovarian cancer that's called high grade serous ovarian cancer. We now know it probably comes from the fallopian tube rather than the ovary, and that's the majority of ovarian cancer. We know that responds extremely well to this combination of surgery and chemotherapy using platinum drugs. So that is excellent. Um, so the majority of women will respond very well to a combination of surgery and chemotherapy. And the other thing, but often, unfortunately, we do have many women who have surgery and chemotherapy successfully at the start will recur. So the cancer comes back in sort of 18 months to 2 years. So, in the context of ovarian cancer, we try and talk about controlling the cancer for as long as possible. And really, that's the starting point, to accept that this is about controlling the cancer for as long as possible. In the best cases, we can have, I mean, at the moment in the UK, on average, we will have about 4 to 5 women in 10 women will survive at least 5 years from the diagnosis of having ovarian cancer. 3 in 10 women will survive for more than 10 years after diagnosis of ovarian cancer. So, but this is expanding, and this is changing, and this is improving as you know each time. So the one thing that there are a couple of things that your listeners can do. Firstly, be vigilant about their bodies and advocate for themselves, and sort of embrace testing without fear. The second thing that makes a difference is that we now, for the majority of women with ovarian cancer, we offer testing for inherited faulty genes. That's quite a useful thing to ask for and be offered, because there are two benefits for that. If you've inherited a faulty gene, or if the cancer itself has a faulty gene, there are some new drugs that are available that work extremely well in such
Okay.
women. So it's really beneficial for women to engage with testing for their blood as well as testing of their tumors. That's happening, and I think it's not universal, but it is happening, and we're pushing hard for it. The other benefit of having testing for inherited faulty genes is that if the woman and her family are happy to undergo testing, then you can get either their daughters tested or their sisters tested, and potentially they could have preventative methods of monitoring or testing to pick things up much earlier. So these are the two things that I'm very keen, particularly for women from minority ethnic communities who don't engage with this extremely well, because we do know that there are lots of cultural implications for inheriting faulty genes. So I think if people can engage with that, there's information that we're producing in lots of different languages that's available on the website. So I think if people could really advocate for themselves for that and have a consideration of being tested, then that would help them and it would help their families. But no pressure; people have to make independent decisions.
And is there anything that women who have ovarian cancer, is there anything that they can do to improve or influence success rates? If they've already been diagnosed, apart from, what you've said before about going along and being tested and, being aware of your own body.
So the things that are helpful are, I think, staying active is very helpful. I think because surgery, the treatment is not, so treatment, particularly in the form of surgery to remove all cancer, is an undertaking. And so the fitter people can be, the better they can be with nutrition. Nutrition is hard, but equally, because people sometimes feel quite full and struggle with eating, but actually engaging with the nutrition and saying, okay, look, what options do I have? And the nutritional build-up drinks, it's fair to say, are quite vile to take. They don't really taste nice at all. But I think if they can engage with that, if they can find out what options there are, and really push with eating little and often, but persevere with eating, persevere with staying active, lots of chest physiotherapy to keep the chest as strong as possible to cope with surgery. I think these are the things that people can really do. There's lots of information, as I said, on the charity websites, but it's, I think, engaging with it with an approach of realistic optimism. I think knowing the odds, but willing to go for it, which is very easy for me to say because I'm not in that position. But I'm just, I'm giving them the spiel. I don't know how I would be under those circumstances.
Okay, thanks. And thanks for mentioning those resources. And what I'll do is I'll put links for those resources with the podcast notes. So it just makes it easier for patients to find out where they can find more information. Okay, and lastly from me, can you speak a little bit about HRT in women who have had ovarian cancer? Because that's a very topical subject at the moment, HRT. And these women, as you mentioned, are by and large postmenopausal women who get ovarian cancer. So I'm sure they'd be quite interested to know what any information you can give us about HRT post treatment for ovarian cancer.
So the first thing to say is the majority of women with ovarian cancer will be quite substantially postmenopausal. So most of their symptoms would have resolved and they will no longer be in that space where they will be needing HRT. That's the majority of women. Mm-hmm. We do have younger patients who will be for whom this is quite naturally a concern. It depends a lot upon their particular cancer and their particular whether it's much more hormone driven or not. However, for the majority of women with ovarian cancer who have the majority type of ovarian cancer, we would consider it reasonable if they had difficult and troublesome symptoms to have, or to at least have a conversation about hormone replacement therapy, have a think about which HRT would be best. Data on HRT is always very challenging, particularly in sort of rarer groups of women, like the women with ovarian cancer. So it's a very individualized decision based on whether that cancer is influenced by hormones or not.
Mm-hmm.
But we certainly wouldn't. I would say have that conversation. Ask, if you have those symptoms, start with asking that question: Can I have HRT or not? And indeed, I always, in fact, in my department, there are two things that I'm very, very keen that our fellows ask. One is about HRT. How are you managing with hot flushes and night sweats? The other thing is about sex. Because I think we're very good at asking how people are in general, how their waterworks are, how their bowels are, how their tummy is, how they're feeling. We don't ask them how well they're feeling in themselves. So we're not very good at picking up low mood, which again we can help with. And we know a lot of women with cancer have anxiety, depression, fear of the cancer coming back, and that sometimes needs more than just there they have a cup of tea, you'll be fine. People need a bit more support than that.
Yeah.
And I think we can almost always have a conversation about how it's impacting on their body image, and whether they want to pursue, how it's impacting on their sex lives, and whether they would want support for that. So these are things that I think we are willing to have a conversation about, and we mustn't consider these things as no, it's not for me.
Yeah, really important points. Easily left out, and you're right. Women have to advocate for themselves, and if it's not brought up, they should feel empowered and not
Absolutely.
embarrassed to bring
Exactly.
that up.
Exactly. And in fact, it's interesting in my experience, it's often the very older women who have the confidence to say, how is this going to impact on my sex life?
Yeah,
Which is lovely, which is absolutely lovely. But I think it should be a conversation. You walk into a gynae clinic, we ought to be able to ask people, how's your sex life? Because I mean,
yeah,
if we can't ask that question, who on earth can?
exactly,
So,
exactly.
but for women, I think it's really important that the first steps in the ovarian cancer are okay, surgery, chemotherapy, and then most women with ovarian cancer, their lives will be characterized by long periods of feeling quite well, followed by perhaps another bout of chemotherapy. Which means that it's really important for us then to think about what would impact their quality of life. Are they coping well? How they're mentally handling all of this, and all the other things that matter. So it comes back to, again, self care, staying well, and feeling empowered to ask these questions, because there's often things we can do to help.
Yeah. Okay. Thank you. So, thank you for those really clear answers to my questions. As you know, before the podcast, I invite patients to submit questions that I ask on their behalf. And we have had quite a few questions for you. Are you happy to answer questions submitted by my listeners?
I'm very happy to do that. I mean, obviously I can't answer specifics in terms of individual
Yeah.
detail, but I can provide broad
Okay.
pointers.
Okay. So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question um, is long, but I've condensed it a little bit, but I think it's really, really important. And I think it typifies a problem that many women may have. So this listener asks, she says, my mum died of ovarian cancer, age 61. Her oncologist recommended that myself and my sisters have a full hysterectomy. And by a full hysterectomy, the patients usually mean the womb, neck of the womb, and the ovaries and the tubes. So my sisters and I were recommended to have a full hysterectomy when we reached age 40 based on the aggressive nature of her cancer. I have multiple medical issues, including rheumatoid arthritis, fibromyalgia, myasthenia gravis, and a spinal cyst which is enlarging and damaging nerves. I'm due to have surgery on this. I have gynae issues, heavy periods, pain throughout the month, irregular periods roughly every 3 weeks, and anemia. I've spoken to genetics and I have an increased risk of getting a female cancer. I want to have a hysterectomy. My other consultants are happy for me to have this, but my gynecologist is hesitant and wants me to have an ablation. So an endometrial ablation, for those listeners who don't know, is where the lining of the womb is destroyed or burned in order to treat heavy periods. So my gynecologist is hesitant and wants me to have an ablation. I'm done with being poked down there. I'm fed up of having to sit on towels or worry that I'll leak everywhere. I'm fed up of having pain, which is in my head, fixable. My other conditions are not fixable. How can I convince my gynae consultant that I've thought long and hard about the options, but have decided to have a hysterectomy, and that is the right option for me? I feel as if I have to fight for everything. I just wish she had my back. So it's a long question, but I thought it just brings out many issues that women have quite frequently, actually, and I see quite frequently in my clinics.
So, firstly, I'm sorry to hear that you're having such a tough time with your periods, and that it appears that that's one component of a number of things that are happening with rheumatoid arthritis and the fibromyalgia and the myasthenia gravis. So, clearly, it's quite complex in terms of managing your general health. So it's unfortunate that your patient is experiencing these things. The first things first, I think, from an ovarian cancer point of view, is to bottom out that risk of ovarian cancer. I think women who are considered to have an inherited faulty gene are actually, if they do have that, it's not clear whether this listener has it or hasn't, because she says the genetics has, if she's been tested, if she carries a mutation, then in fact the service should be very sympathetic to the request for a removal of tubes and ovaries. It's called a prophylactic removal of tubes and ovaries, i.e. a preventative removal of tubes and ovaries. And often we are very sympathetic to the prospect of removing the womb as well at the same time. So I think if she's been tested and she carries that inherited gene, then she needs to identify where the service for BRCA gene mutation carriers is locally, because it's often managed not in the hospital, in whichever, it's not managed in the nearest hospital. So for Birmingham, for instance, it's managed at our hospital, at the hospital I work in. So everyone who needs a risk reduction surgery, which is what this is called, is referred to us. So there will be a hospital in the vicinity who is tasked with providing that service for women considered at higher genetic risk of ovarian cancer. And that would be a very appropriate thing. The genetic service should be able to guide her there. And she should be able to avail that service, which will be, if that's the case, then actually the guidelines are very clear in terms of us offering removal of tubes and ovaries. And often when you're having that conversation, then to say, well, actually, I thank you for removing my tubes and ovaries, but actually I want to remove my womb as well because it's got heavy periods, is a very reasonable ask. If unfortunately for many women, what will happen is that they won't be able to be tested for genetics because the genetic testing has come in now, but it may not have been around for when her mum was diagnosed with ovarian cancer. So, in the presence of a strong family history, but without actual genetic testing, it becomes a little bit more complicated. But it will still be possible to advocate for testing for herself. Because then the genetic service will send you a questionnaire, and if you're more than at 10% risk, then by by nice guidance, she should be able to avail that testing. So that would be a good thing to do. So that's my suggestion. Find out who's responsible for looking after women at high risk of ovarian cancer and speak to them.
Okay, thank you. That's a really good answer. Thank you very much. Okay, the second question is, how can we tackle the inequities relating to ovarian cancer, both globally and nationally?
So this is something that I feel very strongly about. I'm the National Ovarian Cancer Audit Lead. And we know in public domain that only 1 in 2 women with ovarian cancer in England will actually receive surgery and chemotherapy. 1 in 4 women will not receive any anti-cancer treatment across the UK. Some of it is because they will present later and not really be well enough to receive treatment. And we know that there's some variation in the rates of treatment given across the country. So my very strong feeling is that the only way we can reduce inequality is by very clearly having data on the subject. The NHS has funded a long-term ovarian cancer audit that will be starting in April. We have in the British Gynae Cancer Society ourselves co-funded national audits, and the reports are available in public domain. We will be, as part of the new National Ovarian Cancer Audit, will be releasing data into public domain in terms of cancer treatment rates across the country. And I think it is for patients, things improve when patients advocate for things to be improved. And that then means that in the NHS, which is, let's face it, resource strapped and cash strapped and strapped for every resource possible, we need to work together with patients to ensure that women get treated well and diagnosed well. And so I think data is the most important thing, and that's data available for people within the NHS, but that's also data available in public domain. So the data is available in public domain. Patients can go and have a look at it, and I can provide you the links. So that is what I would say, that both patients, cancer charities, and consultants need to work together to look at this data and then to try and secure the best possible outcomes for our patients.
Okay, thank you. Okay, the next question is, I'd like to know whether there is still considered to be a link between HRT, breast cancer, and subsequently ovarian cancer in a patient without genetic predisposition.
So this is a very challenging question. This is a really difficult question. And we have to see HRT as a holistic for what it's intended to be, which is that it supports women with symptoms of the menopause. There is there's protection for the bones. To some extent, there is protection for the heart, although that data is a bit complicated. And there is also a slightly higher risk of breast cancer and a slightly higher risk of ovarian cancer. But we need to weigh that up in total for that individual person and for the symptoms that that individual person has. So I think it's very hard, I think. So for me, what is very reassuring for me is that breast cancer, women who are on HRT with breast cancer are less likely to die of that breast cancer. For me, that's been a very reassuring statistic. So I think individuals have to make that decision for HRT. But what I would say is that having gone through the perimenopausal stage myself, I'm completely sympathetic to women who request HRT, because you don't really recognize it until you experience it, and then you think, poof, Now I get what they were talking about. So I think there's the longer term risks, and the risks are there in public domain. We know. We can give the statistics, but then for that individual, they have to be able to handle hot flushes. They need to be able to go to work. They need to be able to pick up their kids. They need to be able to do all of these things whilst going through the menopause. And some women will not have very troublesome symptoms, and they'll fly through it. And some women will have troublesome symptoms. So I think it's for that individual person to weigh up the odds and decide what they want to do.
Okay. So next question, which you kind of touched on. We touched on before. Is an effective screening test for ovarian cancer on the horizon? So we know there isn't one now, but do we think that there may be one in the not too distant future?
One of the challenges we know is that the most common type of ovarian cancer, high-grade serous ovarian cancer, doesn't come from the ovary at all. It comes from the fallopian tube, and that's a much and that knowledge has been around for maybe the last 10 years.
Mm-hmm.
I don't. It's not on the immediate horizon. So I think we certainly aren't at the point of doing trials for screening with any new tests just yet.
Okay.
Although some things show promise.
So maybe in the more distant future, because it would be amazing, wouldn't it? Because the very nature of the symptoms being so non-specific means it's often diagnosed late. So screening tests would really be a game changer, wouldn't it?
So I think there's certainly lots of research going on to try and find out whether blood tests can pick it up, um, uh, whether cells that are shed through the vagina will be a small proportion of them will be cells from the tube. But I think it's in its infancy at the moment, as in none of them are at clinical trial point.
Okay, thank you. What will be the first line treatment for ovarian cancer patients who are hoping to become mothers via fertility techniques?
Okay, so this question needs to really be answered with a bit of nuance, in that we know young women who have germ cell cancers have excellent outcomes from the treatment of their germ cell cancers, and they will have just removal of the ovarian cyst or removal of one ovary, and they will preserve their womb, they will preserve the other ovary, they will complete their chemotherapy, and the fullness of time will go on to have children, and so that's not so much. So fertility sparing for them is really important, and that's part of. So nobody would. So people will consider very carefully whether that's an option in younger women who have germ cell cancers. For ovarian cancers that are not germ cell, then we know it is possible in an extremely carefully selected group of women. When I say extremely, I mean really, really extremely carefully selected group of women. Because the data is quite fresh, it's quite new, and the data suggests that if it's a stage 1 cancer confined to the ovary of particular types of cancer, and it's actually not even stage 1C, but 1A or 1B, so really confined within the ovary, not on the surface of the ovary, it may be possible for some of those women to preserve the other ovary and the womb, and then to go on to have fertility options. But it's fair to say that that's a very, very carefully selected group of women. And certainly that's something that should be done in conjunction with the cancer centers, with the cancer surgeons, with the fertility centers, and a very careful, nuanced conversation with the patient in a particular group of women with cancer.
So the next question is, I'm 60 and a 4 centimeter simple ovarian cyst. So simple ovarian cyst just means it's just like a water blister, just contains fluid and nothing else. Was found on an ultrasound for tummy pain. My CA125 is low at 13. I've been told I need to be followed up for a year with more scans and blood tests. What is the chance that this could be cancer? And if it isn't, can it turn into cancer later on?
So we know that about one in so even in women past the menopause, about 20% of women who are picked up with having cysts will have these simple cysts. Um, but under 5 centimeters or even under 6 centimeters, a simple water blister has less than a 1% risk of cancer. And one of the reasons why we review the scans over the year is to see whether women are changing or not. And the likelihood of it changing and the likelihood of it transforming over beyond that point in time is actually extremely small. So no one can ever say never for anything in life. It's just simply doesn't exist. I could walk on the road and slip today. But under 5 centimeters for a simple cyst, that scan's been done and it's a transvaginal scan, followed up for a year, I think I would reassure the person extremely strongly that things are highly unlikely to change.
Okay, because as with all intervention, we have to weigh benefits and risks. And if this patient is considering, if the unasked question is, should I have surgery? Then perhaps the risk of surgery
That's right.
outweighs the
Yeah.
benefit of a very
Absolutely.
likely benign cyst.
Exactly. So you lose time, of work, there's recovery time, there's a risk of complications,
Yeah.
and there's this sort of real unnecessary intervention risks from anesthetic, from hospital stay, infections. These all far outweigh the risk of the cyst being abnormal.
Because we operate when we need to, but we try not to operate when we don't need to because
Right. Yeah.
any operation involves even a small level of risk. So that has to be taken into consideration. Okay, next question. Does HRT influence the risk of ovarian cancer? So
Yeah,
you did mention that.
Yeah, we've addressed this, and it's up to individuals to decide whether their symptoms
Yeah, so there's a small increased risk of ovarian cancer with HRT. But
a tiny small risk, but this needs to be placed in the context of bone health and
yeah,
symptoms. Yeah,
again, risk benefit.
ratio.
Yeah, same.
That's right.
Okay. What research is being carried out to help diagnose women earlier?
So, thank you for asking that question, and I could speak for another hour on that. So my own research program is trying to investigate because there's partly about whether we can diagnose women earlier at an earlier stage, but also whether we can diagnose women at a better fitness. So the research that's ongoing. So if people Google rockets, that's the sort of set of trials that I run. We look at a number of different things, the commercially available tests that are available. So blood markers, ultrasounds, specialist ultrasound to diagnose ovarian cancer. We also are doing research into whether tumor DNA can be identified to diagnose ovarian cancer earlier. We're looking to see if hormone profiles, uh, whether if we find out 24 hours of urine in some women with particular types of cancer, we think that the hormone profile in urine can sometimes pick up cancer accurately. So we're looking into that. Research that we're doing with Imperial is very interesting and looks at supermarket loyalty card data to see whether women are self-prescribing pain medication a couple of months before the diagnosis of ovarian cancer. And there's some signals that suggest that although women may not be flagging it up to themselves, or the GP, they're actually having more pain medication, more Buscopan, more Gaviscon, more bananas, more pain medication. I don't mean bananas, but certainly more pain medication, more laxatives. They're going to the supermarket and purchasing them a couple of months before it triggers, and they're actually going to their GP. So that's research that we're doing. We're doing a big study in primary care to see whether we can pick up ovarian cancer earlier. So there's a few things that are going on. that we're trying to see whether we can identify ovarian cancer earlier.
Okay, so a lot of work is in progress. Fantastic. Right, that's interesting. Ovarian diagnosing cancer from your Tesco bill.
That's right. So, but
That's
why
really
not?
thinking out of the box. Actually,
That's right.
that's genius.
So because people self-medicate, particularly
Mm,
the very group of women who don't go to see their GPs. The
yep.
slightly older women who feel a bit vulnerable. So they're going to their pharmacies, right? So they're going to
Yeah.
their pharmacies, they're going to their supermarkets. So can we find out? Can we pick it up? And I think if that approach is right, then you could do that for lots of different conditions, not
Hmm.
just.
Absolutely. Yeah. 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 Okay. And the last question from our listeners: why doesn't the NHS again offer ovarian cancer screening with the current diagnostic tools they have? Would this not help to reduce the incidence and save lives? Now, we know that various, I think, private clinics may offer an ultrasound scan and a CA125, whatever they offer to screen for ovarian cancer. Um, so I guess maybe that comes from that.
Yeah.
Why isn't this offered in the NHS when you can pay for it?
So, unfortunately for the NHS, no, not unfortunately for the NHS to adopt something in a screening program, then it needs trial evidence to show that having a screening program reduces the likelihood of women dying of cancer. We've had one large, extremely well conducted trial in the UK. It's called UK Talks, and it showed that screening women with existing tests, with a sort of a particular type of testing with CA125 to see how quickly CA125 was rising, or ultrasound, did not change the death rate from ovarian cancer, which is the ultimate goal of any screening program. I don't think we've completely closed it yet, in the sense that I think if blood tumor DNA, for instance, the Gail trials that have been conducted, or new research that's happening, so I don't think it's a forever no. But with the current tests that we have, then there is no evidence to support screening.
Okay, thank you. That's really clear. Okay, so there's one more question from me. In your career thus far, you have managed many, many women with ovarian cancer. Given the opportunity, what would you say to women who have either been diagnosed with ovarian cancer or suspect that they may have ovarian cancer?
Firstly, that there are good treatment options available. Um, Clearly, for some women, they will be coming to the end of their treatment options. But for the majority of women at the start, there are good treatment options that are available. So it's to advocate for yourself and advocate um, for your family to or your carers uh, to seek those treatments. And that includes, as I said, the gold standard is a combination of surgery and chemotherapy, testing to see whether you've inherited this faulty gene or whether your tumor is showing signs of that faulty gene, which is extremely important. And we know, certainly from the tumor testing perspective, that only half of women in the UK go through this at the moment. That's the best data we have. So it's asking or advocating for a consideration for gold standard care. I think that's quite important, and that's certainly what and you're working hand in hand with your cancer teams for this. You're not, this is, I don't mean in any way to be adversarial at all. I mean to actively work collaboratively with your cancer teams to go for these things.
Great, thank you. Okay, so finally, Sudha, all that remains is for me to thank you very much for agreeing to be interviewed on the podcast. Thank you for supporting my efforts to educate patients in this way, but thank you mostly for your sterling work in managing, treating, and helping women who have ovarian cancer. Thank you so much.
Thank you very much indeed. Thank you for the opportunity to answer these questions, and thank you for doing the work that you're doing, which is a lot of work at your end to do these podcasts and promoting patients and their families and their carers to be more aware and advocate for themselves. So.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.